So it shows it's good. Hello, good morning. It's 6:30. We're going to get started here with Grand Rounds. I'm Colette Inaba. I'm one of the general surgeons over at Northwest Campus. I am transitioning into the role of chairing the Grand Rounds program here at for our department. Dr. Deb Marquardt has been doing this for probably about 10 years or so and has decided to focus on other roles and responsibilities. And so I'm excited to help take over and help develop our program here. So please send me any ideas for speakers or topics of interest that you'd like to learn about. But for today's Grand Round session, we have one of our Harborview Trauma Critical Care surgeons, Dr. John Scott. After obtaining his bachelor's degree at Harvard, he went to med school at Vanderbilt and then to Brigham Young for his general surgery residency. Midway through residency, he completed a research fellowship at Harvard and earned his master's in public health. He came here to Harborview for his trauma critical care fellowship and then started his faculty career at the University of Michigan. He recently returned to Harborview last year and joined our trauma critical care faculty as an associate professor of surgery and director of ECMO. Dr. Scott CV boasts a number of research and teaching honors and awards. He's a KO8 and R01 funded researcher through the AHRQ and then NIH and has authored over 150 publications. He also holds an adjunct appointment at the UW's Institute for Health Metrics and Evaluation. His research interests include trauma-relevant health policy, health economics, health services, and patient-reported outcomes. He has particular expertise in health insurance policy and evaluation of patient-level financial outcomes, such as financial toxicity, which is what he will discuss with us today. Please join us in welcoming Dr. Scott to present his talk, Curing the Destitution, Understanding Financial Toxicity After Trauma and Emergency Surgery. Dr. Scott.
Good morning, everybody. I'm going to get my timer started here because sometimes get a little carried away. Thank you so much. All right, it's looking at me now. Thanks so much for joining us this morning and navigating the parking and the doors and all that. So I'm glad we made it here. I'm going to talk this morning about a topic that is probably not that commonly discussed at Grand Rounds, but it's probably familiar. It's definitely familiar to our patients. And it's a topic that I think is one of the maybe most, in my opinion, one of the most significant preventable threats to our patients doing well after the care that we provide them. And I think it's also one of the biggest threats to sort of the soul of our profession if we don't sort of speak up and think about it and do something about it. For those of you who I haven't met, I'm John Scott. I'm newly back at Harborview, thrilled to be back here at UW on faculty. And I've spent the last 10 years trying to better understand the impact of unaffordable care on patients that need surgery, especially emergency surgery and injured patients. This morning, I'm going to share a story. The story is built on what I've learned from the literature, what I've learned through my own research, and what I've learned from my patients. And so I'll be highlighting some of the research I've done, but won't go too deep into some of the methods there. But the story is not always encouraging, but don't worry, there's hope for the story because we're at a time in this story that a new chapter is being written. And if, my goal is that at the end of these Grand Rounds, if one person who's listening is thinking a little differently about this and wants to engage in this in a new way, then I think that'll be progress. Let me figure out the forward progress here. Does the button work? That clicker doesn't work here. Let's try a new one. If I can click on the forward arrow, there it is. All right, we're making progress. My disclosures are I speak on behalf of me and nobody else. I will show some stuff that's unpublished and highlight that when I do. So like any Grand Rounds, I'll start with real live patient vignettes. These are real stories of real patients from my real experience from three different places that I've either trained or worked along the way. The first, I was a PGY2. I'm in the trauma bay. We called it in the pit. So I'm in the pit. I'm all excited. I can't wait to run my trauma resuscitations. And a guy comes in who was assaulted. We, descend on him like we do in trauma, and his airway's intact, breathing's fine, heart rate, blood pressure is fine. And he's screaming. And I'm like, oh my gosh, like what, like, let's go save this guy's life. What's going on? And he's screaming and he's screaming. He says, let me leave because I don't have the money to afford this. And we're like, no, you're okay. You're okay. And he's like looking us dead in the eye. He's like, I know my rights. I know I can refuse this. And I know I don't need it and I can't afford it. And I was just like, I had no idea what to do. Here I am, the PGY2, and like ABCs were intact. It was okay. So that was kind of a confusing day. I didn't know what to do about that. Then I was in fellowship. I was walking to work and I walked upon a guy who was laid out on the street. His face was bloodied and looked like he had just been assaulted as well. And I'm in like full hero mode now and like a little more knowledgeable. And I'm going to like come save the day, realizing that outside the hospital, I really have no useful skills for humanity. But I'm there and I'm checking his ABCs. And I said, hey, man, let me call you an ambulance. Like, let's get you the care you need. To which he says, do not call an ambulance. I can't afford one. I'll walk. And I didn't really know what to do, but I called the police to see if they could help him because here in America, the police won't bill you, but the ambulance will. It's kind of interesting there. And then the third patient vignette is I was in my first job as an attending. Had a woman come in after a car crash and a whole lot of X-laps. Y'all know how that works at Harborview. You start to collect them with an open belly. She made it through this really long course. I can't wait to see her in clinic. I'm all excited. She dressed up for clinic. I dressed up for clinic. We have a little moment. We hug and like she's doing great. And I'm so thrilled. And I sit down, look her in the eye, and I just say like, how are you like really doing though? Like what, can I do anything? And we connected. No, doc, I'm fine. And then you can actually see the date here. I got this letter in my physical mailbox the day on Christmas Eve. And in the letter, it says, you asked me like, how am I doing? And the reality is I'm struggling financially. And she asked me if I could help her start a GoFundMe page to pay for her bills. And I lost it and was like, oh my God, I call our financial aid. I was like, do not send her any bills from me. Like, I don't want to get paid any money for this. Like, I don't care. And they're like, no, we've actually already forgiven our piece of that for her cost share. And then come to find out it was all the other pieces, all the other things that she needed to afford is what she was struggling financially with because she had already paid her part of the bill. So these are three patients at different states, different health systems, different times of my training. These stories just kept popping up. And when they do, what do? We just kind of ignore it. And we think that this makes me feel a little funny, but I'm just going to keep on keeping on because I'm a doctor and that's not what we do. So today we're going to cover some pretty simple ideas. And these are the ideas here. We'll kind of march through them. And I will try to bring data to as many of these ideas as I can. I will also try to restrain myself. I am the grandson of a Baptist preacher, and sometimes it gets a little carried away. Fortunately, this mic is not a lapel mic, so I'm like stuck here. So that's probably good for everybody involved. But the first idea is a pretty simple one. And it's that, we should probably insure the uninsured. Novel concept here this morning, but we got 30 years of data that have demonstrated a lack of health insurance is probably not good for your health. And so this is New England Journal, 1994, and one of the first studies to show the difference in ruptured appendix based on insurance status out of San Francisco. And I read this and thought, oh, look, isn't that interesting? Uninsured patients have a 1.5 times greater odds of showing up with ruptured appendix. Maybe this is delaying care, not able to access care. But also maybe it's just sicker patients because the Medicaid patients you'll see are like just as high, if not a little bit higher. And so, this is an observational study. This is just taking a slice of data and looking at it, and you can't really draw too much from it. The tricky thing is there's not a lot of randomized controlled trials on health insurance. There are two, the Rand Health Insurance Experiment and the Oregon Medicaid Experiment, and we can go talk deep about all those later. And my request for secondary analysis of those data has been declined. But the good news is we live in this really interesting time in America when it comes to health insurance, because this is the line of the proportion of Americans that are uninsured, leading up to some pretty interesting timelines. So in the mid 60s, it's hard to explain just how big a deal Medicare and Medicaid being signed into law was. Like, can you imagine if we didn't have Medicare, Medicaid? That's like so many of our patients. And this was, we're going to talk a little bit more about the context of this coming forward, but that was this huge precipitous drop in the proportion of Americans that didn't have insurance. And then you'll see it was flat for a little bit and it starts going up. We'll talk about that in a bit too, where that rise through the 80s. And then it kind of leveled out for the duration of the time that I was thinking I wanted to be a doctor and all. And then two big things happened, one in 2010 and then the other in 2014. And this is the first parts of the Affordable Care Act. So everyone on like this side of the room probably got to stay on their parents' insurance till you were 26. And that's thanks to the dependent coverage provision. Before 2010, it was state by state variation. A lot of them, the day you turned 18, congratulations, you can serve in the war, buy cigarettes, and buy your own health insurance, but you can't stay on your parents anymore. And it varied by state. This was a quick and easy win because no one in the government had to pay more, and people were like, yeah, this is good. Look, we reduced the uninsured rate. So that was that first little blip. The second one was Medicaid expansion, supposed to be a national program. Is healthcare like broccoli? That's a whole conversation. Went to the Supreme Court, and the long story short is it was state by state. To this date, 37 states now. It was 34 till recently. Every state that's ever put it on the ballot, the people have passed it. And so if a state has not passed Medicaid expansion, it's because the legislature has elected not to do it and elected not to let the humans vote. Because when the citizenry votes on passing Medicaid expansion, passes every single time. Just something about. But the bottom line is 20 million fewer people are uninsured now. So we have this like really interesting time from like 2010 through now. So we have about a decade where we've been sprinkling insurance into the population. And if you're a health services researcher, that's a really interesting time to study these dynamic effects of health insurance. And there's a couple ways to do that. So the dependent coverage provision and Medicaid expansion are two. You can say I had these like really nice, I love them, but a little nerdy slides on difference and difference analysis and regression discontinuity and instrumental variable analysis. And then I was reminded that this would be at 6:30 in the morning. And so if that interests you at 6:30 in the morning, please come find me because I would love to talk to you about it. You can talk to Nina and Alex. I will talk for hours on end about these models and tweak and poke. But that's what we've used here to look at a couple of these different things. And the first question we ask is, if you gain insurance through one of these programs, do you maybe not delay care as much? Because the hypothesis was if you don't have insurance, maybe you delay care. So is there this counterfactual? Can we tease that out? And lo and behold, one of the first things we looked at was that perforated appendix inspired by the 1994 paper. And what we found is about a 15% relative reduction in the uninsured rate in the group that was eligible for the DCP, and about a half the same size reduction in perforated appendix rate. A good friend of mine, Andrew Lair, who's at Dartmouth now, looked at this for Medicaid expansion, and they found in Medicaid expansion state, huge drops in uninsured rate were associated with big drops in perforated appendix, perforated diverticulitis, ischemic limbs for vascular disease. And then similarly, looking into aging into Medicare at age 65, we found big drops in the uninsured rate associated with big drops in needing emergency surgery for things that could otherwise be elective. And so is this really people not delaying care? Like maybe this is a bad proxy. Do we know that this is actually what's happening? Turns out there are these studies. I'm off again. Let's Try that. Okay. Turns out there are these studies out there where you ask people, did you delay care because you can't afford it? That's really convenient if you want to answer that question. And so a lot of folks have used these data sets to look at this, and lo and behold, with each of these programs, if you ask people, you look and you see a large reduction in the uninsured rate, and you see a large reduction in the proportion of people saying, yes, on a survey, I am delaying care because I can't afford it. So that's pretty compelling, taking all these pieces together. We have these physiologic markers suggesting people are showing up sooner for care. Then when we ask people, are you delaying care? They're saying, no, I'm not delaying care as much as I was. And that's compelling. And the question is, are they right to do so? And, are they really getting bills that they can't handle? Like, what's an objective way to measure whether or not people are getting bills they can't handle? Because nobody wants to pay a bill. I don't want to pay a bill for my cell phone. And so, how do you really know? And it turns out there's a way to capture this. And the World Bank and the WHO follow this thing called catastrophic health expenditure risk. And there's actually a little carve out specific to surgery, to if you were to need surgical care. The simplest way to define it is to say if your out-of-pocket spending on medical care is more than 10% of your annual income. So for our residents, coming up with a $7,000 out-of-pocket bill, I don't know how easy that is for y'all, but when I was a resident, I couldn't have done that. There's a couple other ways to define this. It's a little more nuanced, but this catastrophic health expenditure, it's been around for 40 years. We don't actually measure it in the US, but we measure it everywhere else in the world, and we tell other people they should too. It's a very US thing. And it turns out when we looked at this in trauma and emergency surgical patients in the US, if you're uninsured, yeah, you're right to be worried about these bills, because 7 out of 10 uninsured patients are a single bill, a single hospitalization is meeting that annual year-long mark of bills that would be catastrophic for your income. Fortunately, it looks like these insurance gain, these ways to gain insurance actually help protect against this. So when I was a fellow, we looked at this here with the Harborview Trauma Registry, and we found that Washington Medicaid expansion associated with a huge reduction in the uninsured rate, as it's supposed to, but also a really large reduction in the risk of catastrophic spending after injury. And that's almost entirely due to Medicaid patients. And then another fellow that I've worked with, Pooja Nyman, she looked at this in aging into Medicare with that regression discontinuity. And what we found, again, was large reductions in uninsured rate associated with quite sizable reductions in catastrophic spending. So insurance does what it's supposed to do most of the time, is that it's supposed to be for financial risk protection. It's supposed to be that you pay in this insurance pool, you have this big bill, insurance helps you out. Kind of. So we looked at this nationwide. Charles Liu, who's a good friend and who was a NCSP research fellow, he wanted to look at this nationwide, not just surgical patients, everybody in America, using the medical expenditure panel survey. And what we found is the ACA was associated with 2 million fewer people each year with actual observed measured out-of-pocket payments more than that catastrophic spending threshold. That's a huge deal. As you can see beforehand, there wasn't a lot of change happening, and this is after the dependent coverage provision had started, but there wasn't a lot of change happening around 2014 when Medicaid expansion happened. Each year, 2 million fewer people are faced with these sort of crushing out-of-pocket payments. But what's interesting is, see this big turquoise bar in the middle that doesn't change? Those are privately insured patients. So that was if the whole point of moving from uninsured to insured is supposed to save you financially, that's not actually what's happening here. And so it brought up this concept of maybe being underinsured. So the metaphor you'll see for insurance is this umbrella. It's oh, you're protected, whatever, the rain is, I don't know if the rain is your bill or if it's probably your bill. Maybe that's what you're protected from. But turns out a lot of people get umbrellas that look like this. And I know we don't really use umbrellas in Seattle. We just walk through the rain and just deal with it. But that's what a lot of these folks are trying to do too. So idea number 2 is protecting the underinsured. So some pretty compelling data that not having insurance associated with delays in care. When people gain insurance, those delays go down. When you ask them, if they're delaying care less, they say yes. And then if you look at the bills that they're being forced to pay, they're actually quite significant and they're going down. So that's all pretty interesting and compelling. We wanted to look at this concept of being underinsured, which is essentially where the amount of cost sharing that you have is more than you can really afford. And many of you, you don't have to raise your hands, but when I was in your seats, I was in what's called a high deductible health plan. I'm now over 40, and that sounds less like a good idea for me. But when I was not, I was in one of these high deductible health plans. And now about 1 in 3 employer sponsored health insurance plans are high deductible plans. And so these are people with jobs. These are people with jobs that provide insurance, and they're electing for these high deductible plans where they pay lower premiums for higher out-of-pocket spending. Well, not everybody's choosing this. Sometimes they're being forced into it because their employer, that may be the only thing that they offer. And they're meant to be combined with these health savings accounts. So you're like putting money in. It's like your extra Roth IRA. It's like this great thing. If you're wealthy, it's lovely and you should do it, and you can make a lot of money and like spend it if you need it. But the CEO of the hospital and the janitor have the same deductible, which is like really fascinating, even though their income could be 100-fold different. That high deductible that they both have to pay is identical. So it's not necessarily one size fits all. So we wanted to study these high deductible health plans in patients with emergency general surgery conditions and see if those delayed presentations and worse outcomes are, could you tease those out? And what's interesting about patients with high deductible health plans is they're younger, they're wealthier, they're healthier, they have more education. So these are the young invincibles. And we looked at people that were employed through one of the largest employer-sponsored health insurance programs that we have claims data on, 18 to 64, high deductible versus not. We looked at common EGS conditions. And when we looked at the table 1, we're like, oh, there's going to be no finding here because like it's going to go both ways. And like these people are going to have better access and better outcomes in every way. And lo and behold, they had a 34% higher odds of delayed presentation, despite the fact that they were younger and healthier and wealthier. And when we looked across, just if it doesn't touch the red bar, then it means they had more delayed presentation. And so it's like every group of people are affected by this across the board. Maybe not those still on their parents' insurance. We didn't target that too much, but pretty much across the board, this was affecting people. So these young, healthy, wealthy people, they probably signed up for this because they're cognizant of how much they can afford to pay on health insurance. And lo and behold, so this is like perforations are happening, like macrophages and stuff are like different because of people's health insurance policy. It's kind of an interesting idea. And then we looked at that catastrophic spending risk. And turns out if you are a low income individual, so these are working folks, okay? These are people with jobs. These are people with jobs whose employers give them insurance. And they're trying to make a living and trying to get by. And if you have an emergency general surgery condition, then almost 70% of them are paying catastrophic levels of out-of-pocket bills. And so it just seems like maybe this isn't working as designed, because not only are you showing up with worse disease, the payer has to pay more, the hospital has to pay more. You're in a really bad way. Meanwhile, if you make more than $100,000 a year, this is not an issue that you face, which is maybe why policymakers and physicians have a blind eye to some of this. And so if you're from minoritized populations or you don't have a college degree, you're also at particularly high risk for these catastrophic bills if you're in a high deductible plan. Don't just believe me. Others have looked at this too. My buddy Andrew Larrigan out of Dartmouth looked at this, and the good folks at Stanford looked at this as well for appendicitis, diverticulitis, groin hernia, and across the board, they're finding similar things. High cost sharing, high deductible health plans associated with markers of delayed presentation across a variety of diseases. These are in 3 different databases, 3 different definitions of high deductible healthcare plans, 3 different conditions. So what we've learned so far is that not having enough financial risk protection can lead people to delay access to care and have worse outcomes. So uninsured, they have delays in seeking care, they have worse presentation, and they have worse financial risk, and that's felt. And all of these things were made better by these individual programs to expand health insurance coverage. The underinsured, though, is a little trickier because these folks have insurance, they're working, they're employed, they have jobs. Like this is what we say the goal is to get to. And yet the design of these health insurance programs is like not so favorable for them. And it's resulting in the same problem: delays in seeking care, worse disease at presentation, and worse financial risk, despite the fact that they're healthier and wealthier and younger. So all of this up until now has been the notion of the affordability of care and getting to the hospital, how you show up, how you get there. But as I heard the discussion this morning, y'all are discharging all your patients today. Congratulations. I'm excited for you. And so once patients get discharged, turns out these problems don't go away. And it's kind of hard to measure them because they're not in our claims data. They're not in HCUP. They're not in inpatient databases. And so a lot of the health services research up to date, up until now, has not been able to talk about them too much. But that's where we'll move on to this concept of financial toxicity. So it seems out of place as a word in the surgical community. It's stolen from the cancer community. They have chemotoxicity from chemotherapy. They have radiation toxicity from the radiation therapy. And financial toxicity is thought of as the iatrogenic. So that's the most important part. It's the iatrogenic complications of having to pay. And in cancer, it's this like slow burn. You get this diagnosis, and for a lot of cancers, not all, but for many, it's kind of this like long, slow burn, and it's kind of this like slow dread and slow drain. In trauma, you woke up that morning and got in your car and started driving to work and just thought you were going to have a normal day. And so, people called it financial strain, financial ruin. Doesn't matter what you call it. The reality is, it really puts patients at risk for poor health outcomes. So it's one thing to say like we shouldn't bankrupt people because like that's bad to do morally, ethically. I don't like that. It's another thing to say I want my patients to have the best possible outcomes. We just like put a bunch of people on ECMO this week at Harborview, and we will move heaven and earth to get our patients the best possible outcomes. And I would posit that this is a piece that is a little cheaper than ECMO that we maybe should think about and could affect some more lives. So when we think about long-term outcomes in trauma, this is how we normally start. So you woke up that morning, you got in a car crash, you weren't expecting it, you get hospitalized, and then after your hospitalization, you have these new physical needs and mental health needs. And like that's it. But you'll notice there's a lot of blank space on this slide. So I posit that there's a little more going on if you talk to the patients. And that's this. So they had this unexpected medical bill that they weren't planning for, and that comes with it this expectation for out-of-pocket spending. Meanwhile, their physical health has declined, and maybe they're not able to work. For us, we would hope our employer wouldn't drop us if we got injured, but plenty of employers out there have every right to terminate your employment if you can't work. You'd love to think that that's not true, but it's not, but it is. So now you have these bills you can't pay, and maybe you have reduced monthly income as a result of it. So now you're faced with this choice. Am I going to pay off my medical debt, or am I going to pay for food? And so this was the third patient I was telling you about. And those two together conspire to just create this like stress and pressure and like, what am I going to do about my finances? And one thing that people choose to do is to delay the care that they actually need. That we say, okay, you're going to follow up with like 17 specialists and like, oh, see your PCP. Oh, and you screen positive for PTSD. Here's a flyer. Go talk to your PT, or go talk to your, get your physical therapy. Oh, you're out of PT visits. Well, there's an ATI down the road. Maybe you can, find some time there. Good luck. And actually Harborview does a ton to support their patients, more than any other place I've ever been. And so it's actually one of the draws back here to me is to be a place that sees the whole patient and sees this whole picture. But this is still not like ingrained in the way we think about what our patients need after injury. But this is kind of our schema of how financial toxicity might work. And ultimately it comes down to this piece right here, which is reduce health-related quality of life. Because if they're not getting the care they need to get their jobs back, if they're not getting the care they need to get the mental health and physical health recovery, then we are missing this opportunity to get the best possible outcomes for our patients. Financial toxicity, it's subjective, it's objective. There's a lot of ways to look at it. So I got a grant to look at this when I was at Michigan. And I simplified it into kind of two arms of the grant. And the first thing we did was look for patient-reported measures of this concept of financial toxicity. Because again, most of our databases don't have these variables in them. You got to call patients up. We're getting, promise measures and these sort of physical, mental health outcomes, but there's not a lot of people asking about financial outcomes as a result of it. So there's this big statewide trauma collaborative in the state of Michigan that we latched onto, and we called patients up and asked them how they're doing, and did a bunch of different types of questions using established measures for health-related quality of life. And at the bottom there, you'll see financial toxicity. We added that into these series of questions. And we called a bunch of people, and it's growing and growing. These slides are a little bit old. But the two things we wanted to do was first figure out, after you get injured, what's your risk of experiencing financial toxicity as thing one? And thing two, if you experience financial toxicity, is that associated with worse health-related quality of life? Because that's what our beautiful cartoon suggests, but is that actually happening in humans? And then we, adjusted for all the things you would adjust for in a trauma registry, because that's the data we have is a trauma registry. So our patient traits, our injury traits, our treatment intensity, and health system traits, as a good trauma HSR researcher would do. Interestingly, this population had 3% uninsured because Michigan expanded Medicaid, and the folks that are home to answer surveys are a little older and they don't have jobs necessarily anymore. And so this is like a group that we were like, oh man, we're not going to like pick up signal here because these folks are going to be doing fine. So when we first looked at the risk of financial toxicity, we found it's everywhere. So these are the elements that we looked at that came from that rubric of problems with bills, income or job loss, problems with non-medical bills, and then delayed or foregone care due to costs. And it's like 20 to 40% of patients. And then when we looked at who had one or more element, 2/3 of patients had one or more of these financial toxicity elements when we just called them up and asked them at different points over time. We tried to look at what are the risk factors that put someone, that predict this, thinking that if you had like a worse injury or a longer ICU stay, or maybe if you like broke your leg or your arm and you like couldn't move, that's like worse than a, grade 2 liver injury. And it turns out the only things that came out are sort of health policy related things. It was nothing about their injury traits, nothing about their treatment intensity. There is a little signal for EMS air transport. That's another talk for later we can get to, but it's mostly about like, what's your health insurance, what's your income? This makes sense, but what was a little striking is that whether or not you go to the ICU, whether or not you had surgery, whether or not you went to IR, these like high things we think are high costs, it's just the hit of a trauma admission alone is a lot. It's a little foreshadowing for later in the talk, but we did find risk adjusted when we looked across different hospitals. We found quite different, almost a twofold difference from one hospital to another hospital and how much people were expressing this financial strain. And this is adjusting for all those things I just told you were significant of age and income and insurance. So it made us think that maybe there's some way the hospitals playing a role in how this plays out. So the second thing we looked at is if you have financial toxicity, then what's your risk of having poor long-term physical and mental health, the outcomes that we say that we're doing all this for. And here I'll show you a bunch of bars, and the dark bars are people that had financial toxicity. And the dark bars are shorter than the light bars. And what that means is across the board, everything we looked at. So EuroQual index is like a health-related quality of life, balled up number. And then self-reported health turns out is a pretty good proxy. If you ask people how healthy they are, they tend to know. And it turns out across the board, having each of these one financial toxicity elements was associated with worse health. And especially if you said, I can't afford the care that I need. And so it's not causal, it doesn't prove it, but it's pretty compelling to say, maybe if we got people the care that they needed and it was affordable, then maybe they'd have better health. Now, this is each of these individually. The question is, if you stack these on top of each other, how does it look? And to take a page out of the playbook of the good Dr. Alex Hernandez, if you went to Schilling, look at that line. It's a nice line. And so what it shows here is people that had no financial toxicity have less anxiety, problems with mobility, problems with pain, And if you have more of these financial toxicity elements, it's like a monotonic association across the board. This is not causal. This is observational data, but gosh, it's kind of there every way you look at it, and it's pretty compelling. And it makes us want to look at it a little bit better. So what we found from this study is financial toxicity is super common in our cohort of really privileged Michiganders that almost all had insurance. So that's interesting. There's kind of this dose response as financial toxicity gets worse, your health gets worse. And it turns out it's not actually about how badly you were injured. It's just the wallop of that hospitalization and what it did to take you out of the game. Now, the good news is this is being used to inform some work by the AAST. We actually have a call at noon today to talk about just this. Good timing. Where we're working with the AAST to say, if you want to measure this, there's a couple other places around the country that are doing it. We should coalesce on a single definition so we can track the same things and we can compare how people do at Stanford to how people do in Boston to how people do in Seattle to how people do in Ann Arbor, and actually be able to compare apples to apples. So that's one thing that's kind of exciting right now, is that we're coalescing as a group to make sure we're measuring all the same things. And this is happening right now. And if you want to know more about it, talk to Nina or Alex, because they have been doing some deep dives with some national data on this. The second aim of my K was to say, can you really trust patients? Like, we ask patients, but, what do they really know? Maybe they're biased and they're just telling us stories. And is there an objective way to measure the financial impact of a trauma hospitalization? And it turns out getting pre-injury surveys on trauma patients is kind of hard to do. I think there's some places in Seattle you could go and do some surveys, and if you did a longitudinal cohort, you'd get a couple hits of yep, we have some pre-data on you and some post, but it's hard to do in trauma patients, bad jokes aside. But it turns out there is a way to do that with credit data. And so we, through a very fancy de-identified way, created de-identified registry where we linked our trauma registry to Experian data. So essentially we had anybody that was injured in 2019 through 2021, and then we had quarterly credit data. Turns out Target and Walmart have these data on you, and Experian will sell it to anybody. It's amazing, as long as you go through their way to de-identify it. And so it's kind of incredible that you can get it, but you can get it. And what I'm going to show you is some unpublished stuff that's real early, but what's nice is say you got injured, here, then all the data points to that side are your pre-injury data, and all the points to this side are your post-injury data. And you can do this fancy panel data analysis to try to look at this. And so what I'll show you here is this is medical debt and collections. Now, why would people have medical debt show up on their credit report? Well, it's supposed to be because things that show up in your credit report tell lenders if you're credit worthy or not. If you have had the unfortunate experience of trying to buy a house in Seattle, you know that you gotta really work on that credit score, trying to get that up beforehand. Turns out medical debt is not a predictor of that. And it is a bully tactic used by people that want you to pay the bills, that they threaten you by worsening your credit by sending it to Experian. And actually Experian won't take it anymore. After these data were produced, Experian said, well, this is probably hurting people, and it doesn't predict creditworthiness for a mortgage or a car or anything else. And so they changed the rules on what it takes to get to actually show up on your credit report. But these data were beforehand. So the key here, though, the reason for that that aside is that this is not about the actual bills you owe. This is whether or not your hospital sent those bills to Experian for them to show up on your credit report, and they wait 6 months to do it. So we looked by payer and uninsured, private insured, Medicaid patients. We zeroed everybody out at the time of injury. And you can see there's a tiny bit of noise ahead of time, but not a lot happening in people's medical debt before their injuries. And then quite a big jump here afterwards. So the start from the bottom up. So Medicaid, it's pretty compelling, very good at financial risk protection, or at least not getting medical debt, essentially zero change if you're Medicaid. For the private insured, the average change in the population is about $500. Well, there's a lot of zeros in here. So it turns out that if you're privately insured and you have medical debt, the average debt that you have is about $1,500. But this is just the population average from like a causal analysis, trying to look at that. And then the uninsured patients up here at $1,500, it turns out 1 in 10 uninsured patients owe over $11,000 in debt. And again, this is not, they may have already paid some. This is what got sent to Experian to show. But this model lets us tease out pre-post to say, is it really related to the trauma? And it suggests, based on your health insurance coverage, it probably is really related to the trauma. Next, we look by income. You could probably draw this graph yourself now. If you make more than $100,000, life is good. Policymakers, physicians, where do they fall on the line? Do they think this is a problem? Maybe they don't. But the average income, household income in America now, mine is 62, 68. Has it hit 70? I don't think it's 70. It's in the 60s. So that's the people in the purple bar here. That's the average worker. So these are people with private insurance. So key here is it's not that the poor folks don't have insurance. These are people that are working, they have jobs, they have employer-sponsored insurance, they're doing everything right. And if you're a low-income worker, you are almost as bad off as somebody who's uninsured when it comes to medical debt and collections. Then we looked at it across the board saying like, who's really affected by this? And this is not the dollar amounts. This is the proportion of people that had medical debt and collections. So it was 1 in 5 went to about, a little more than 1 in 4 across the board. The length of the arrow tells you like how big of an impact it was on that group, and kind of how far it is to the right will tell you just like where you ended up. So by sex, men had a bigger hit than women. By race, you'll notice that minoritized groups, Black patients and Hispanic patients, started off with more debt, and the arrows are longer. And that has to do just with a lot of structural inequities and who has income, who has assets, who has what health insurance. And then by age, this is a problem of young people who use their bodies to generate income. It is not a problem of people over 65, not so much if you're over 80, it's not really a problem at all. And then unsurprisingly, the insurance, so uninsured, not super protected here. That's a pretty long bar, and it puts you way to the right on this graph. Well, you'll notice about Medicaid, it's way to the right, but it's a super short bar. So it's a trauma registry, right? So a lot of these people maybe came in uninsured and got Medicaid enrolled retroactively. We only know what they discharged with. So I think that's why that 43% is really high on Medicaid. Those people, a lot of them may have been uninsured to come in. But what this shows you is the protective impact of getting Medicaid is how short that bar is compared to the other. And then unsurprisingly, right, you could expect this, is that higher income folks, 3% to 7%, they're doing okay. Lower income folks, over half are in a bad way. So I mentioned that the hospital variation had some signal when we did the patient-reported outcomes. This is, we looked at risk adjusted for all the patient traits and insurance traits and all the things that we have. We looked at hospital sort of contributable margin to whether or not you have medical debt and collections. And just like any Caterpillar plot, you can just plot them out and to say anybody that confidence interval crossed that red line, they were a normal hospital, had like the expected amount of medical debt among their patients. But these light blue hospitals had much less medical debt than one would expect. And the dark blue hospitals had patients with much more medical debt than one would expect. Again, this is adjusted for age and insurance and income and all those things. And when we plot these two out, the low outliers, they're just not sending people's debt collections because you don't have to. And turns out it doesn't actually help recoup the money because they sell it for 1 cent on the dollar. That's how much they sell it to collections agencies for. Meanwhile, some hospitals seem like they're doing a whole lot of it, and that'll be important. So, like, here's where we are in America, is that you too can listen. This is a great podcast, Arm and Leg, highly recommend it. There's a great podcast on when hospitals sue patients, part 1, because you need at least 2 parts to tell this story. And this is available in your pocket on Apple Podcasts, only really in the US markets though, because it's not really a thing to our Canadian brother. Do we have Canadians here? Any Canadians in the room? There you go. Yeah, I see you. I see you. There you go. Yeah, talk to your friends back home about this. And they're like, what, I don't understand. How's that happen? So how did we get here? How did we get to the point where young, working, low-income folks are getting injured, and then they're trying to recover, and then hospitals are either suing them or they're sending their debt to collections agencies, and it's showing up on credit reports. It's just like, it doesn't feel good. Doesn't seem like a good situation. Doesn't seem like what we would design a system to do. And there's a pretty interesting story that if you'll bear with me, I'll try to retell in a short fashion. You know, like the villain origin stories are like very popular. You know, it's like, oh, you know, as a kid, you learned they were bad, but really they were just a victim of their circumstance. And I think actually a lot of hospitals are probably just a victim of circumstance. I also think some hospitals are villains. But you know, this is all over the news. And you know, I'm not singling out anybody. I did look up, UW hasn't been in the news about this. So, you know, anytime I give this talk somewhere, I have to look ahead of time to, not that I would put it on the slide, but just so it's not as uncomfortable. You know, UVA sued 36,000 patients. That's not a good look. Hopkins got a lot of flack for it. So did shock trauma. Easy to hate Yale, very fun to hate Yale. Yale was like the biggest expose. Heartless Hospital. It's a Wall Street Journal. It was like they went after him with a pretty good hit piece. Le Bonheur down in Memphis. I mean, they're just like 2 feet into this game. They actually own the collection agency, so they sell the debt to themselves, and then they go. Don't make this stuff up. It's real. You know, when patients can't pay, hospital sues. So this like looks bad, but you know, you only hear bad news in the media. You don't hear about like the hospital that's doing good thing. You know, we need like rigorous peer review, like, you know, our literature, is it there? And yes, it's popping up more and more as people look at it. And there's a lot of data specifically looking at hospital lawsuits against patients. And the Pareto principle shows up in a lot of places of it's about 20% of hospitals responsible for about 70 to 80% of suits when they looked at this in Wisconsin. Because these are public records. You can just go to the courthouse and you can look this up. That's how a lot of these studies are done. And what's amazing is a guy who wrote a really interesting book on this, Luke Messick, I'll show you his book at the end. He did this when he was a resident in Rhode Island. And his like hospital CEO called him into, you know, he got in some trouble, and they're like, we don't do this. What are you talking about? And he's like, these are like public court records. Like, this isn't a hit piece. This is just like publicly available information. And the hospital CEO didn't even know what's happening. And so how did we get here? So, you know, here's 100 years of history in a single slide. You're going to love it. But, you know, looking at the role of hospitals in healthcare, when, you know, it used to be when this is before Harborview was Harborview, is King County Hospital. This was the first King County Hospital, according to the internet. And hospitals were a charitable place. And you didn't want to go to hospital because hospitals are where people go to die. And it wasn't like, oh, I'm going to the hospital. This is great. It's like, oh, I'm going to the hospital. Here we go. And over time, there was this redefining, especially, you know, Jim Crow South, moving into the Depression, there's this redefining of what like the deserving poor is. And a bunch of private hospitals started showing up that were either affiliated with like a particular belief structure or something that kind of carved out like their version of the deserving poor. A lot of the like famous East Coast hospitals came up around this time, and they're these private hospitals that were sort of for one group of people per se. The origin stories aren't told that way, but it's interesting. Public hospitals are now bearing more and more of a burden of maybe the less deserving poor. And then the 60s came along, and we mentioned Medicare, Medicaid was unbelievable, huge change that happened in 1965. But what it did for hospitals, they're like, hey, why do we have to do charity care now? Because our seniors are taken care of, and like poor people are taken care of with Medicaid. So like, why do we even have to do this anymore? And what it took to be a tax get tax exemption status for a hospital changed. And so you no longer had, now charity care still counts, but you don't have to do charity care to get tax exempt status now. You can do research and teaching and other methods. And then if you remember that first slide of the uninsured in the 80s, there was that little uptick in the uninsured rate. And that's because Milton Friedman and Ronald Reagan were going to, you know, solve all our problems by cutting government spending. And a great way to cut spending at your state level and not lose a lot of voters is to cut Medicaid enrollment in half, which is essentially what happened. So So right when the hospitals are like, we don't actually have to do charity care, do we? Now those safety nets have bigger holes in them than they had before. And so now hospitals have more uncompensated care than they were anticipating. And so it's just like two pieces of the balance that are just putting more and more pressure on the hospitals. So what do hospitals do? They try to charge more. As they try to charge more, and then managed care comes in, and y'all have seen the graph of hospital administrators from the time of, before and after managed care. And we're putting more of the cost onto patients. And so reimbursement's going down because patients can't pay. We've showed you that already, and prices keep going up. So if you're a hospital, you're feeling this squeeze over time that it's not any one policy, it's not any one thing, but there's kind of this new reality of what it means to be a hospital and the financial pressures that they're facing. Because the reality is, this is spending on healthcare as a part of our GDP. It's a single line. Care has never been more expensive, and it doesn't appear to be getting cheaper. Every policy to save money is cost money. More patients are underinsured with these high deductible plans, a graph we showed you before. And then after 2016, something happened in 2016, there was an election or something. After that, the more and more pieces of the ACA have been dismantled. Now we're rolling back Medicaid expansion. New work requirements are making it harder to enroll. And so the uninsured rate, after like the greatest reductions ever, that 20 million win, is kind of floating up a little bit now as well. And so all of these are coming together, that hospitals are in a tough way and patients are in a tough way. And so it used to be that hospitals were in the community and they would just sort things out directly with the patients. And now there's kind of this, middle folk of these debt collections agencies. And they say, look, hospitals, you go keep saving lives. We'll take it from here. We'll go sort this out. No big deal. And they used to consign it, where they said, hey, give us a fee and then we'll go get this for you and we'll give you the money back and we'll take a slice. And then that wasn't working so well. And so they said, tell you what, we'll take it a penny on the dollar. We'll just buy your bad debt. And hospitals were getting no pennies on those dollars. So they say a penny on the dollar is better. But like, that's how much hospitals are making. So hospitals aren't staying afloat by sending their debt to credit agencies, because like it's such a tiny fraction of their bottom line. But it's just business as usual. Like, nobody thinks they're doing a bad thing. They're like, oh yeah, and then you have debt, and then the credit agencies, they'll give us a little bit of money for it. Not credit agencies, sorry, debt collections agencies, they'll give a little money for it. And so we all took a Hippocratic oath. Most people that work in hospitals did something like it, but you know who didn't take a Hippocratic oath to do no harm? Is people that work for debt collection agencies. And so there's this great hashtag, sue no harm. So these are extraordinary collections actions that are very much legal in the United States of America. If you're a not-for-profit hospital, there's some limits on this. If you're a for-profit hospital, there are almost no limits on this. We'll talk about by state. And this is selling medical debt to collections, reporting it on credit agencies, denying care to patients with unpaid bills. A great quote from Congress in the 80s is, you can't get blood from a turnip, but you can keep a turnip from coming back to your hospital. And that's like one of the biggest strategies, that hospitals are like, hey, you couldn't pay, so go to Harborview, go somewhere else. They're garnishing wages, they're putting liens on houses, foreclosing on homes, seizing bank accounts, and my favorite is body attachment. You can't actually put people in jail. Debtors' prisons went away in like a long time ago. But if you don't show up to court for some of this, then you can be put in jail. So it's not, people aren't getting jailed commonly, but it's a thing. So this is the state of our union here, is that 100 million Americans hold medical debt. So there's like 300 and something million Americans. It's almost 1 in 3. 2/3 of bankruptcies are somehow linked to medical debt. It's a little hard to know what caused bankruptcy. It's normally like a straw that broke the camel's back, but 2/3 of people that file bankruptcy have medical debt. And then this is the number I want you to just kind of like sit with for a hot second, which is that our health system, well, they say every system gets the outcomes that it's designed to get, right? It's like perfectly designed to get the outcomes that it actually gets. So our health system is perfectly designed in a way that 200 billion with a B dollars are placed on the backs of the ill, the injured, and the grieving. And like, that's how it works in America. And like, that works fine. That's how the system is designed. That's what we, do. And, before you start feeling bad for the health insurance companies, because when the ACA was coming out, they're like, oh, we can't insure all these. If we insure all these people, we will go broke, because our whole game is only insuring the healthy people and then denying claims. If you've watched any Glockenflecken, highly recommend. Glaucom Plugins' lens on health insurance is quite accurate. But they're all doing okay since the ACA was signed. So this is the stock price, which CEO reimbursement is linked to for like a lot of our publicly traded private health insurance companies. They're doing okay. If you want to sell your soul and make a lot of money in your 401k, United would be up almost 1,800% since then. And if only Google could keep up over the same amount of time. So Google would not make it on this list. And so when your health system is designed in a way that $200 billion of debt is put on the back of the ill, injured, and the grieving, and health insurance companies are doing better than Google financially, it makes you wonder if that's like the best design. So in the last couple minutes here, I just want to give some encouragement that this is a solvable problem. We know what works to improve the uninsured rate. We know what works to improve underinsurance, this concept of like means-based deductibles. I mentioned that the hospital CEO and the janitor have the same deductible if they're in a high deductible health plan. You can really easily just peg it to their income. The employer knows the income. They have that data. It's a really easy fix, and you can do it without making premiums go up. But for the sake of time, I'm gonna move through this quickly. The good news is states are doing this all over. They're putting in these patchwork protections against medical debt, and looking at different policies at the state level, sort of like these little labs out there of health policy labs of like different ways to look at this. So, you know, there's some limits on foreclosures and liens. Washington generally does pretty good. Would love to see them show up on this one. Limits on credit reporting, limits on wage garnishment. Texas is leading the way. Like that Texas doesn't let you do it at all. If only we had the moral rectitude of Texas and the rest of the country when it comes to wage garnishment for medical debt, then we'd all be a little better off. And then when you can, what you can do with sending bills to collections. And the point is there's a lot of different policies at the state level that you can do. I'd say the first one is don't let hospitals deny care to people with unpaid bills. This was supposed to be part of the ACA. Hospital associations didn't like it. They teased it out. There are little pieces in there, but they're toothless. If you want to learn more about this, these advocacy groups are doing incredible things. $4 has essentially like navigated the cheat codes to how to navigate the financial system at every hospital in America. So you say, I'm John Scott. I was, injured and I went to this hospital. Like, how do I do this? Help me out. And so it's like a private group that does patient navigation of financial resources in every hospital. RIP medical debt is awesome. They're like, wait, you can buy medical debt for a penny on the dollar. So we can just like forgive it, but we can buy medical debt for a penny on the dollar. And John Oliver, if you've watched John Oliver, they like bought like $6 million of medical debt and just like pressed a button and made it go away and stuff like that. And I think that's good use of comedy. And so, what we've learned, okay, I'm out of time. What we've learned is delaying seeking care, foregoing necessary care, showing up with more complex disease, having worse clinical outcomes, having more costly episodes, having worse long-term health, having worse physical health, erosion of trust. These are all the consequences of care that's unaffordable. But we can do something about it because states are doing it. People are calling for it. And if we just ignore it and it doesn't make us feel good, so we just go on to the next thing, then it's just going to keep happening. But what I would recommend, what do we do about it? Well, you can educate yourself. These 2 little viewpoints are like 1,000 words each. They're great. They tell the story of debt collection. They tell the story of medical debt in the US and what we can do about it. We've written a review in Journal of Trauma, and a second follow-up to that one's just coming out right now. Kaiser Health News and NPR did this great expose on diagnosis debt. And this book right here, Your Money or Your Life, by Luke Messick, tells a great history of how this happened. Do some research to look into this. And a shout out to Alex and Nina, who are doing just this right now. We're analyzing national data to look at this at a nationwide level. We're doing a secondary analysis of randomized trial data on social work interventions to see if that can actually move the needle as well. And because of those 2, we're hoping to design an intervention to start studying this start at Harborview. And there's a lot of sites around the country that want to team up with us to do this. And then lastly, like, educate yourself and don't be scared to talk to your patients about it. Learn how the system works at your place. And this one's really controversial. People say, no, you can't. You have to like keep that line. But like, it affects our patients' outcomes. And I think we have to engage in everything that prevents patients from having the best possible outcomes, because that's kind of where it starts and ends for us as clinicians. And this can't be this like thing that we ignore because the patients aren't able to ignore it. They don't have that luxury. And then this last one is engage policymakers. If people know who's doing this stuff in the state here, let me know. Would love to learn about it. I'm new here and just feeling my way around. But with that, I'm nearly over time. Thank you very much. Happy to take any questions. Yes, please.
What types of interventions are you planning on testing here?
So it turns out most of the people that are getting sued or are having problems with medical debt actually qualify for at least some portion of hospitals' charity